Adverse institutional experiences are a risk factor for chronic illness, discrimination, and unconscious bias of gender, religion, race, ethnicity, health, ability, income, sexual orientation, and disability by doctors and healthcare, insurance, schools, legislative bodies, employers. The experience of being doubted, dismissed, humored, or ultimately harmed by medical professionals and other people in positions of relative power is a common subtle form of trauma. And it's highly, highly stressful when you experience it. Because no matter what you say, they just bloody look at you through their lens of comprehension. More often than not, it is an uneducated perspective. And that in the end will harm you and cause trauma. It's massively stressful.
Really interesting research on this, and it's quite strong. And I recommend people to read this book. It is fascinating. What happens is that when you have more unequal societies, when there's a bigger gap between the rich and poor, it makes everybody more stressed because people are constantly comparing themselves to each other. We call this status anxiety. America is a great example of the most extreme form of this. And you look at their health outcomes, a lot of this is being driven by the psychology of looking at, and a lot of it's materialism based, but this is what happens. And in fact, there's lots of data even showing that they did this Whitehall study looking at civil servants, and they found that ones at the bottom of the ladder in terms of their jobs, who felt that they were more undermined by their superiors, they were again less control, more stressed, they had increased levels of fibrin in their bloodstream. So their blood was more clottable and they suffered more heart attacks as a result of it. So let's also understand these structural drivers as well. And Michael Marmot says this, and I found this really fascinating, because we have to think about this when we talk about policies, government policies, when they keep talking about we're creating all these jobs. It shouldn't be about what jobs are being created. What's the quality of those jobs? Because actually, again, if you are in a high demand, low control, low paid job, it is effectively a death sentence. Let's just change the narrative. Let's talk about it. Make everybody aware of it. This is not just, it's not good for health. So a poor quality and stressful job can be more damaging to health than being unemployed. And that's from Michael Marmot. So I think when we look at any entity and any business, we need to think, what's the overall net effect of, and we think about even our own lives with what we do. If we are contributing back to society, we are also more fulfilled, but society also does better too. Okay, this is it, right? So let's talk about this dimensions of power. What do the big corporations do? And how do they control the narrative? So this is a great paper, which is from Corporate Practices and Influence on Health. So the dimensions of power on the left there, you see, is that what they do is there's a one-dimensional view which talks about power over decision-making, control over the political agenda. The two-dimensional view is power to define issues and potential issues. And then third, which is actually very important, power to avert conflict and keep conflict latent. This is what corporations do. So that basically making sure conflict between the interests of the powerful and those over whom power exerted is kept latent, is kept out of the spotlight, is not made, the general population doesn't know what's going on, they don't even know that they don't know, right? How do they do this? Okay, political environment, they are a huge influence on politicians. They do this through lobbying, through being on committees in government. If you're a politician, I speak to politicians all the time, and I find a lot of the time, there's no malice involved. They are literally just hearing one side of the story from lobbying from big corporations, whether it's food or pharmaceutical industry. And then I come along and say, hold on a minute, that's not true. Do you know about this? And like, what is it? It's extraordinary. The lobbying it's an invisible form of power in exerting influence over laws and regulations. What else? Preference shaping. Okay, so corporate foundations and philanthropy. Think of Bill Gates. Do you know the Bill and Melinda Gates Foundation is heavily invested in stocks of pharmaceutical companies, McDonald's and Coca-Cola? Bill Gates is a very influential man. That is a huge conflict of interest. They capture the media. 80% of the broadcast media in the US is owned by 7 big corporations. You know, people's opinions, most people's opinions are actually shaped by broadcast and print media. So again, people are only getting one version of the truth, and that's not societies we want to be living in. And again, it, you know, ultimately will cause harm, especially when it comes to health. Knowledge environment, funding of research, we've talked about it. Most of the funding of research is coming from the drug industry. Legal environment, so they limit liability. So even if they commit harm, the shareholders, the executives are not held liable. Nobody's held liable. This is a legal entity that is the corporation that is there just to produce profit. It's not a human entity. It is very anti-human. Unregulated activity, and then threat of litigation and preemption. So people, public health advocates, whatever else, we're constantly nervous sometimes of saying certain things because they've got very huge legal power to try and silence us. And then the extra legal environment, opposition fragmentation. We've seen it throughout the pandemic. Very credible doctors and academics have been silenced. They've been smeared. This is all in the playbook. It's all there. It could have all been predicted, the crisis we're in right now. This has been going on for many years. We need to understand this if we're going to combat it. And of course, this is then, it drives the poor health, the macro social determinants of health. So let's just start and remind ourselves what the actual, I think this is the best definition of health I found and from the WHO. So it's a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And a couple of, I think, really good definitions of public health, because again, it's about our identity as public health collaboration. I think we need to acknowledge this. So the science and art of promoting health, preventing disease and prolonging life through organized efforts of society. And also public health is a science and art of organized societal efforts to ensure and create the conditions for the highest possible level of health and well-being of the populations, consistent with the values of social justice and human rights. But where are we in public health? It's unfortunately a very dire situation. So we're not making any significant inroads, certainly in the last decade. And we all know that because either as members of the public, as patients, as doctors, we see the suffering around us, and we know that there are worsening issues around mental health and physical health. I think this analytical framework for teaching and practicing medicine helps us understand the problems that we're in, the issue that we're in. So as doctors, as healthcare practitioners, our role is to improve patient outcomes. What does that mean? It means reduce suffering. The ultimate purpose of knowledge, certainly for doctors, is to reduce human suffering, manage risks, and treat illness. And there are 3 components to that are crucial. Our individual clinical expertise, our clinical knowledge, our experience, best available evidence, and last but not least, patients' values and expectations. We call that shared decision-making. Doctors ask patients, what's the matter? Whereas health coaches will focus on what matters to you. We need more doctors to be actually focusing on what matters to you. And there's evidence, very good evidence, how that will improve patient outcomes. The 2 most important aspects for a doctor, if I'm teaching medical students, I tell them clinical history taking and empathy. So history taking is actually the most important thing to get the factor to get the diagnosis. There's very good research on this. In fact, the Nobel Prize-winning laureate Bernard Lown, cardiologist, actually did an analysis of this many years ago and calculated about 80% of your diagnosis comes purely from the history, from the conversation. About 5% from the examination, 5% from simple tests, 5% from more sort of elaborate tests, and 5% you don't ever get a diagnosis, but the patient gets better. So the reason that's important is I've increasingly seen, and I get referrals from doctors in the US, very, eminent doctors, patients coming to me certainly in my private clinic with just test results and want me to interpret test results. And I'm saying, hold on a minute, I don't treat test results, I treat the patient. What is the history? Because actually, a lot of this over-investigation, looking at just results, is actually not very healthy. Increases health anxiety, you don't get to the diagnosis, you can go down the wrong track. So let's just, I just want to remind people here that the history is the most important thing. And of course, it doesn't cost anything. It's about your clinical knowledge. And of course, empathy is really important for patient satisfaction. If you're not an empathetic doctor, you are going to certainly fall short of improving your patient outcomes and making your patients feel happier, giving them hope, giving them empowerment. Okay, so what's wrong with the best available evidence, the second component? Well, as we all know, as many of you know, that evidence has been corrupted by commercial interests. And if you're using evidence that's biased and corrupted and incomplete, you are going to get suboptimal outcomes or even cause harm to your patient. So what are the factors behind that? Just to remind everybody, so you've got the biased funding of research that's funded because it's likely to be profitable, not beneficial for patients. Biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, big problem, really big problem, especially now. Commercial conflicts of interest, of course, defensive medicine, and last but not least, the inability, medical curricula that fail to teach doctors how to comprehend and then effectively communicate health statistics in a way that patients can understand them. Okay, so how do we get through this medical misinformation mess? How do we survive it? How do we combat it? Because I think most doctors are unaware, certainly, that of the poor quality research that contributes to overuse, underuse of effective treatments or safer, simpler, cheaper treatments, even underuse of lifestyle, avoidable adverse events, missed opportunities for right care, treating the right patient with the right drug at the right time through informed consent, and of course, huge amounts of waste. In fact, the wastefulness has been estimated in the US. I mean, 20 to 50% of healthcare activity either harms patients, is wasteful, or is inappropriate. I mean, that's a huge amount, up to 50% of all healthcare. And that's rooted in a very commercialized system of healthcare. So what are the key points? Much published research is not reliable, offers no benefit to patients, or is not useful to decision makers. Most healthcare professionals are not aware of this problem, so that's another issue. There's a great quote from Noam Chomsky, the American economist, who says, the general population doesn't know what is happening, and they don't even know that they don't know. Apply that to doctors as well. They also lack the necessary skills to evaluate the reliability and usefulness of medical science, and then patients and families then lack the relevant, accurate medical evidence and skill guidance at the time of medical decision-making. And I can tell you, and this is quoted from John Ioannidis' paper, ignorance of this problem is even at the highest levels of academic and clinical leadership is profound. People that over the years as a junior doctor I thought were all knowledgeable and knew everything were actually, very, to put it politely, very unaware of these issues around evidence, whether it's about sugar or whether it's about statins or cholesterol. So don't presume, because they are eminent, that they understand the evidence. This is, we are here for evidence-based medicine, not eminence-based medicine. Unfortunately, a lot of people, a lot of the healthcare problems are being driven by eminence-based medicine. So what can we how do we get to the roots of this a bit further? So obviously, a lot of the best available evidence when it comes to treatments is driven by drug industry-sponsored clinical trials. But what's the problem? Well, we have to start by acknowledging this very clear, simple fact. Pharmaceutical companies and medical device companies have a legal obligation as businesses to make a profit and declare a shareholder dividend by selling their product. They are not required to give you the best treatment. You can also apply this to the information when it comes to food industry and the marketing of products, low fat, high sugar, all that kind of stuff. Marketing is healthy. In fact, actually, if someone wants to do a study, I'm sure they will find that most of the products that are marketed, that need to be marketed as healthy, are probably going to have the opposite effect on your health. So I always tell my patients, if it's marketed as healthy, don't eat it. But the real scandal is this: the regulators fail to prevent misconduct by industry, and that doctors, institutions, and journals that have a responsibility to patients and scientific integrity collude with industry for financial gain. Talk about the socioeconomic factors. It's a bit vague. It comes up quite a lot. A lot of public health professionals talk about it, but actually it's probably the most important. but it needs to be redefined, and I'm going to help redefine it. So, they've mentioned here poverty, education, housing, and inequality. So what's the biological mechanism? What's going on? Well, I'll come to that in a second, but the reason why policy-based interventions to make the default choice healthier will be more effective because they reach all parts of the population and are not dependent on a sustained individual response. Because of course we can adopt these lifestyle changes and go low carb and everything else, but it makes it harder if the food environment is giving us or promoting foods that are the opposite of that. We need to redefine it to change the narrative to help people understand this better, okay? I would say that it's better to talk about the biopsychosocial model. So what's going on here? We're talking ultimately at the root of this, of chronic psychological stress. If you don't have a secondary, school education, if you're unemployed, if you're in a high demand, low control, low paid job, it's very, very detrimental to health.
That is very near and dear to my heart, which is how we begin to use the science of adverse childhood experiences and toxic stress to change the way that we respond to early adversity in childhood.
We also know from separate data, if you're a child who is a victim of severe psychological abuse or physical abuse, that can knock off at the extreme end 20 years to your life expectancy. This is epigenetics. This is, the single most important relationship to the development of a human being is the one between mother and child. That nurturing relationship is so important. That actually determines health outcomes further down the line for lots of different reasons.
This journey really started for me a little over 10 years ago when I finished my pediatrics training program at Stanford University. And I wanted to go and work in a place where I was needed. I wanted to be somewhere where I could make a difference. And so I went to work in one of San Francisco's poorest and most underserved neighborhoods, a place called Bayview Hunters Point. And when I got there, I was seeing patients, and I noticed a very disturbing trend. A lot of folks in the community, teachers and principals, and people who work in after-school programs, they would send me patients, and they would say, Dr. Burke, can you please take care of Bobby, right? Bobby, he can't pay attention in class. He gets upset really easily. He's hitting the kid next to him. Please, Dr. Burke, he's got attention deficit disorder. Can you please see him and put him on some medication, right? And I said, please, sure, come on, send him down. But when I actually did my job and I did a thorough history and physical exam, what I found was that for most of the kids that I was seeing, I couldn't make a diagnosis of attention deficit. It seemed like there was something else going on. Somehow I was missing something important. So I threw myself into the research and the science about how stress in childhood could affect the health of children, because the thing that I was seeing, that history that I was hearing over and over and over again, was the story of children growing up in a violent neighborhood. Children witnessing domestic violence in their home. Children who, unfortunately, were dealing with parents who were addicted to substances or who were severely depressed or experiencing other types of mental illness. So when I threw myself into the science, I was looking through all these research papers, and then one day my colleague walked into my office and he said, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my medical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everyone should know about. It was done by the CDC, the US Centers for Disease Control and Prevention, and Kaiser Permanente, a major hospital group in the United States. And what they did was they asked 17,500 adults about their histories of 10 categories of adverse childhood experiences. For every yes, you get 1 point on your ACE score. And then what they did was that they correlated these ACE scores against health outcomes. Now, since this original study was done almost 20 years ago now, in 1998, in the US, 32 states now collect data on adverse childhood experiences at the state level. And of those reporting their data, all of them report between half and 2/3 of the population with at least one adverse childhood experience, and between 13 and 17% of the population with 4 or more adverse childhood experiences, right? This is not isolated to one tiny community. In my home state of California, we looked at adverse childhood data across race and ethnicity, and we found that in California, it was almost equally prevalent. We found it in every race, every ethnicity, every income group, right? From the wealthiest to the poorest income group. The only thing that we noticed in our income data was that for individuals who had 4 or more adverse childhood experiences, they were more likely to be living in poverty as compared to individuals who had 0 adverse childhood experiences. So the first thing that they found is that this is incredibly common and incredibly widespread. But the second thing that they found was even more striking. What they found was that there was a dose-response relationship between adverse childhood experiences and health outcomes, meaning the higher your adverse childhood experiences, the worse your health outcomes.
I have done videos on the Adverse Childhood Experiences study before, but I just decided to make another one. Based on the prevalence of adversities they had seen in the obesity program, Felicity and Anda sorted their definition of abuse, neglect, and household dysfunction into 10 specific categories of ACEs. Their goal was to determine each patient's level of exposure by asking if he or she had experienced any of the 10 categories before the age of 18. 1. Emotional abuse. 2. Physical abuse. 3. Sexual abuse. 4. Physical neglect. 5. Emotional neglect. 6. Substance abuse in the household, e.g. living with an alcoholic or a person with a substance abuse problem. 7. Mental illness in the household, e.g. living with someone who suffered from depression or mental illness or who had attempted suicide. 8. Mother treated violently. 9. Divorce or parental separation. 10. Criminal behavior in the household. Each category of abuse, neglect, or dysfunction experience counted as 1 point. This is just what Dr. Nadine Burke has explained in the video. So she wrote a book about this. And she does additional scoring. In her book, Dr. Nadine Burke-Harris writes, quote, "Given what I'd seen in my patients and in the community, I knew in my bones that the study was dead on. It was powerful evidence of the connection that I had seen clinically, but had never seen substantiated in the literature. After reading the AIEs study, I was able to answer the question of whether there was a medical connection between the stress of childhood abuse and neglect and the bodily changes and damage that could last a lifetime. The body senses danger, and it sets off a firestorm of chemical reactions aimed to protect itself. The other important thing that the CYW AIEs questionnaire did was go beyond the traditional criteria developed by Felitti and Anda and asked about additional risk factors for toxic stress. We don't call them ACEs because they are not from the AIEs study, and we don't have the large body of population data to tell us odds of disease, but our experience in Bayview told us that our patients faced other adversities that repeatedly activated their stress response systems. Our research team worked actively with the community, youth and adults, to learn what the greatest stressors were in their day-to-day lives. Informed by these insights, we reworked our screening tool to include other factors that we believe may also increase the risk for toxic stress. We score these supplemental: community violence, homelessness, discrimination, foster care, bullying, repeated medical procedures or life-threatening illness, deaths of caregiver, loss of caregiver due to deportation or migration, verbal or physical violence from a romantic partner. But most important, the body remembers. The stress response system is a miraculous result of evolution that enabled our species to survive and thrive into the present. We all have a stress response system, and it is carefully calibrated and highly individualized by both genetics and early experiences. There you have it. This is a very good article on toxic stress. I will put the link in the description. And in my opinion, autistics should be screened for ACEs. We are more prone to toxic stress than average people. And maybe they should add some categories for the autism population in particular. The journey toward mental wellness and self-care can be especially challenging for trauma survivors. Trauma literally means wound, injury, or shock, according to the International Society for the Study of Trauma and Dissociation. It refers to extreme stress that overwhelms a person's ability to cope, writes Esther Giller of the Sidran Institute. The impact of trauma makes it difficult for survivors to understand their own experiences and can interfere with their ability to get the help they need. A trauma-informed therapist develops skills to become mindful of the impact of trauma to aid in working with clients. This awareness is the basis for a therapeutic relationship that is responsive to the needs of trauma survivors. Understanding the trauma-informed approach is important because it can help all of us recognize the challenges trauma survivors face when seeking healing and support. When a person is not yet able to come to terms with threatening events, that person is left with a host of intense responses and symptoms that tell the story without words, and without the knowledge that we are remembering events and feelings from long ago. I think she means flashbacks, things that trigger us, can trigger emotions, or even memories of the trauma. Unresolved trauma negatively impacts physical, emotional, and psychological health. The survival response system may become chronically activated, resulting in long-term feelings of alarm and danger. Tendencies to flee or fight under stress, debilitating feelings of vulnerability and exhaustion, or an inability to assert and protect ourselves, explains Dr. Janina Fisher. A trauma-informed therapist must recognize that potentially traumatic events may be subtle and hidden as well. Trauma can occur from neglect of a child's emotional experience. It could be that a parent is just not emotionally present for their child, even if the child's financial and physical needs are met. A relationship does not have to be abusive to inflict trauma. Having a non-protective parent can also be traumatizing. For example, ignoring when a child is bullied at school can leave a child feeling abandoned and helpless. A parent's substance abuse causes both visible and hidden injury during a child's development. A parent may misuse drugs or alcohol and become unable to care for children responsibly, including driving the car while intoxicated. This is neglect. A parent's outbursts of anger or rage can create hidden trauma through the interpersonal relationship with the child. Since I have no access to any such therapist that is really trauma-informed and works on a nervous system-based approach, I did a lot of research, reading, learning about trauma, trauma-related issues, stress-related issues. I could not get a handle on that. And then, through my dear friend Dream, I came across this way of treating trauma, which works very, very well. How Amanita muscaria helps manage stress and depression from a medical point of view.